let's talk about a scenario for a myocardial infarction. And so this example was a 54-year-old patient that was woken up in the night with substernal discomfort. They said it was a burning pain. And a lot of the time when you see that, you start thinking, well, is it really an MI? Maybe it's just reflux or something like that. But they also noted that the patient had left-sided neck pain and shortness of breath. They have a history of a bunch of things that show that they probably have coronary artery disease. So they had hypertension, diabetes, 30-pack year of smoking. And this patient had an S4 heart sound. Okay, so they had an S4 heart sound on top of all this. And you need to know that S4 is seen whenever you have decreased compliance. And so we're going to go into some of the details about S4 here in a second. But the number one thing I want you to remember is that if you have decreased compliance in the heart, you'll have an S4 sound. And so the most common here is going to be ventricular hypertrophy, acute MI, aortic stenosis, and HOCM. So pause the video and write these conditions down that are associated with an S4 if you do not have them memorized. So one more time, the things that cause S4 is ventricular hypertrophy, which you get from chronic hypertension, acute MI, aortic stenosis, and HOCM. And so those are all kind of like the really bad times that you see in S4, but you can see S4s also in young adults, children, and healthy older adults. But for your boards, no, ventricular hypertrophy, acute MI, aortic stenosis, and HOCM. All right, and then the test taking point that I want to mention about this question is that any time that you're unsure on the USMLE, whether it's a GI cause for chest pain or a respiratory cause for chest pain or something like that, if all things being even, if you're really stuck and you've tried going through all the different answer choices, look at the patient's past medical history. If they start giving you like 3 or 4 different data points that indicate that they have coronary artery disease, they're probably trying to clue you into that for a reason, right? And so that's not to say that somebody can't have gastritis plus a huge history of cardiac issues, but on the boards, they're trying to point you in a specific direction. And so use those context clues if all else fails. All right, next, let's talk about HOCM. And so HOCM is abnormal mitral leaflet motion. And so the buzz phrase here that I kind of drilled into my head for boards is systolic anterior motion of the mitral valve. And so I remember the mnemonic SAM, systolic anterior motion of the mitral valve. And so it's going to be a crescendo, decrescendo, systolic murmur. And the most common place that you'll have left ventricular wall thickness is at the basal anterior septum. And I put this in all caps because it was something that I kept forgetting. So the bottom front of the septum is where you're going to have the most left ventricular wall thickness. So it's basically, here's your heart, bottom, front side of the septum. And remember the mnemonic SAM, systolic anterior motion of the mitral valve. All right, now let's talk about coarctation. So Takayasu arteritis can rarely give you coarctation of the aorta. It's definitely possible, especially in patients younger than 50 years old, and usually they're of Asian descent. And remember, coarctation has the 3 sign. You'll see that on your chest x-ray, and it shows the sign due to aortic indentation. And I'm actually going to have an image of that in our high-yield images review. And so to diagnose coarctation, you could diagnose it with an echo. You could also diagnose it with a CTA, CT angiogram. And so the treatment is oftentimes a balloon angioplasty, a stent, or a bypass if it's very severe. And so coarctation has a left interscapular systolic or continuous murmur, but it's not heard really well in the supine position. And so if they say, what's the best way to diagnose? I would go with a CTA. UWorld recommends an echo for these patients, but as a vascular surgeon, we rely on the CTA much more than the echo. And so the note here that I want you to know, something else that was tested in this question is that T-wave inversion and a downsloping ST segment depression can be normal findings in somebody that has long-standing systemic hypertension. So just kind of a little quick hitting fact that was something I really liked from this question. All right, let's talk about amiodarone. So if you've been through my endocrine review, you know that amiodarone has a ton of effects on the thyroid. Okay, so you can get hypo or hyperthyroidism from amiodarone-induced thyrotoxicosis. And you can also have liver damage. So it can hurt your thyroid, it can hurt your liver, it can hurt your heart, it can hurt your lungs, it can hurt everywhere basically. And so basically, half the patients that take amiodarone are going to get side effects, and other ones to know about are heart block, pneumonitis, hepatotoxicity, blue-gray skin, and that's obviously a huge buzz phrase for amiodarone, but you don't see that a whole lot in real life, and then corneal microdeposits. But if they say what's the most common out of all side effects of amiodarone, the most common is going to be chronic interstitial pneumonitis, and so they'll have an amiodarone cough, and that's how it generally will present in real life and on the boards. And some other high-yield side effects that you should know is digoxin. Digoxin is always tested for its side effects. Most common is going to be GI. These patients don't really have like thyroid and hepatic dysfunction though. So if you start seeing that as an answer choice, you're thinking amiodarone. But they both can cause GI side effects. Digoxin is primarily GI. It can also cause a yellow tint to your vision. But amiodarone is really one of those drugs that has a super narrow therapeutic index. All right. Let's talk about another murmur that you can find with aortic stenosis. So like we said before, you can get an S4 anytime that there is decreased compliance in the heart. So we talked about that with the chronic hypertension, acute MI, HOCM, aortic stenosis. You can have an S4. But you can get a soft single S2 with aortic stenosis as well. And so aortic stenosis, you have that day crescendo that ends into a soft S2. And keep in mind, anytime we're talking about these murmurs in the heart, is the more severe the stenosis or regurgitation, the different variables that you can have affecting the murmurs. So you might see that one resource says you'll have an S2, one says you'll have an S4, some say you'll say paradoxical splitting with aortic stenosis. I'm trying to give you a good variety of the different ways that these murmurs can present, because you can get that A2 after the P2 with aortic stenosis. Sometimes the A2 and the P2 combine and you'll have just one soft single S2. And so just don't be thrown off by that. Be aware of the different variety of findings that you can have, but don't let this throw you off in the practice questions. All right, let's talk about adenosine or vagal maneuvers. When would you use those? Well, if the AV node is firing rapidly, so let's say somebody has supraventricular tachycardia, adenosine and vagal maneuvers will both slow the conduction via the AV node. And I remember the D in adenosine is D for decrease conduction. And it can basically cause a transient AV node block, and it can terminate AV node dependent arrhythmias. So anytime you have AV node dependent arrhythmias, you can rely on adenosine or vagal maneuvers to help block those arrhythmias. And it's basically because you just go in there, you stop the AV node temporarily, and it helps stop that aberrant firing that you can have with an AV-NRT or orthodromic AVRT. Adenosine can help in identifying P waves to clarify the diagnosis of aflutter or atrial tachycardia. It can also terminate paroxysmal supraventricular tachycardias, like we said, by interrupting the AV node reentry circuit. So definitely adenosine is a medication you don't want to sleep on for the USMLE. It gets tested a lot. Something else that I wanted to make note of here is that IV nitroglycerin is most commonly used for an MI, but it can also be used for acute pulmonary edema or hypertensive urgency. So we don't really use it that often for hypertensive urgency in the hospital, but it can be. All right, another point about aortic stenosis. So aortic stenosis is whenever the valve's area is considered less than 3 centimeters, but you generally don't get symptoms until the valve area is less than 1 centimeter. And so usually you'll have a low pulse pressure with aortic stenosis, less than 25 millimeters of mercury, but aortic regurg generally has a huge pulse pressure. So it can oftentimes be like 50 plus points for aortic regurgitation. So aortic stenosis is a small pulse pressure, and oftentimes you will not have any symptoms whatsoever until that valve area is less than 1 centimeter. All right, we are going to stop here for part 1 of the cardiology review. Hopefully this was helpful.